Catch up. I'm Jordan Kenny and we're live on the BBC News NI website and Facebook page and on the BBC iPlayer for the next 25 minutes or so. Thanks for tuning in, however you're joining us. Don't forget, if you're watching on Facebook, to get involved in the comments section. If you've any questions about what's being discussed tonight, leave them there and we'll try and get to them before the end of the programme. Now, ministers at Stormont heard today from the Health Minister, Robin Swan, about mounting pressures on hospitals across Northern Ireland. The past weekend saw what's been described as the worst 48 hours since the pandemic began. They also discussed a crackdown on large retailers who have been keeping the non-essential side of their businesses open. We've had lots of questions sent in about all of this and more. Joining us tonight to answer them is one of the experts who advises the executive on their decisions, Northern Ireland's Chief Scientific Advisor, Professor Ian Young. Professor Young, thanks for coming on to the programme tonight.
Well, Jordan, thank you, and good evening to everyone who's listening or watching.
I suppose before we get into everything, a lot of us will know you from the Stormont press briefings, but for anyone who's maybe not familiar with your role, would you mind briefly explaining it to us? Because you're not a politician, right?
I'm definitely not a politician. My day job under normal circumstances is as Professor of Medicine at Queen's University in Belfast, but I also act as Chief Scientific Advisor to the Department of Health, which is a part-time appointment. And what that means is that I give scientific advice to the department and sometimes more broadly government on lots of different issues, but clearly that has all been overtaken by COVID at the moment.
So, Professor Young, it's clear that our hospitals are under some serious pressure at the minute. Can you just give us an idea of the position they're in at the minute?
So the number of patients who've been admitted with COVID to our hospitals has been increasing steadily since Christmas. That's a consequence of the very large number of cases that we saw due to pre-Christmas relaxations and Christmas bubbling. We're now beginning to see the case numbers fall, but because there's a delay between somebody becoming infected and the risk of being admitted to hospital, then the number of people being admitted to hospital is going to continue to rise for a bit longer. And the number of inpatients in hospital, because once people are in, they stay there for a number of days, won't peak until late January sometime. At the moment, there are more people with COVID in hospital than there have been at any time since the beginning of this epidemic. And those numbers, we know, without doubt, will increase further in the next few days.
Arlene Foster and Michelle O'Neill were speaking earlier today, and they said they were concerned both about employers requiring their staff who could work from home to work from the office, and also people mixing in larger retailers that are currently still open. Tim has been in touch with us and he's asking about where areas where transmission of the virus is more likely to occur. Are these places mentioned by the First and Deputy First Minister today where the virus is spreading most rapidly at the minute?
At the moment, the message to everybody is to stay at home as much as possible. And large segments of society, as we all know, are shut down. There's no hospitality sector. There aren't any gyms open. Sporting venues are closed. So in general, people are mixing in pretty limited circumstances. This virus spreads anywhere where people mix, particularly indoor settings. The number of indoor settings which are open at present are relatively few and include those mentioned today by the ministers. So those are the locations where somebody's probably most likely to catch the virus when they're outside the house, although people can also catch the virus outdoors if we get too close to other people.
So do you think there could be more restrictions brought in to, I suppose, limit the amount of people in these places?
We've seen a good impact of the restrictions which have been in place since the 26th of December. That's why the case numbers are now beginning to fall, but we want them to fall as quickly as possible. We're still seeing well over 1,000 cases per day on average, and that's a huge number. If we think back to where we were, for instance, in July, when there were only 2 or 3 cases per day. So there's still a big problem, we need the numbers to drop off much more rapidly. And that's why we need everybody to stick as strictly as possible to the stay-at-home message at the moment. If people do that, I'd be hopeful that we won't need further restrictions to be brought in. But, that's not certain. It depends on how we all behave.
Well, moving on to the vaccine, a detailed plan for the rollout was published earlier this afternoon. According to that, everyone over 75 and the clinically vulnerable, as well as frontline healthcare workers, will all have been offered the vaccine by early March. Just firstly on that, what's the difference between the vulnerable category and the extremely clinically vulnerable category mentioned in that plan?
So the clinically extremely vulnerable category are a special group of individuals who, by virtue of usually a quite serious underlying medical condition, are particularly susceptible to severe illness when they catch the virus. Those people will have been notified through their general practitioner that they're in that clinically extremely vulnerable category. In terms of the vulnerable, I guess that's a broader group, and it includes everyone over a certain age, for example, because we know that there are much worse outcomes with this virus the older people are. For every decade or so, certainly over the age of 50, the risk of severe illness or even death if somebody catches the virus increases quite significantly.
Well, like I said there, according to that plan, everyone over 75 and the clinically vulnerable frontline healthcare workers will all have been offered the vaccine by early March. Does that mean, Professor Young, that we could expect restrictions to be eased quite significantly by then?
The impact of the vaccine we're going to see firstly in terms, I hope, of reduced numbers of deaths. The focus initially in terms of the vaccination programme is on the groups who are most susceptible to the very severest illness. The pressures in our hospitals are driven more by infections in younger people, in the under 70s and even in the under 60s. So it's going to be a bit longer until we see reduced hospital admissions. And I think we're likely to need to have some restrictions in place, certainly well beyond March, though I hope that it'll be possible to have relaxations compared with where we are now.
Well, over the weekend, obviously, Matt Hancock, who's the UK's health secretary, he said that by the autumn, the vaccine will have been offered to everyone aged 18 and over. Does that mean restrictions will be eased more so in the autumn time then?
Yeah, I'd be confident that we will not need to have many restrictions in place by the autumn, if any, although there's always uncertainties around this virus and there will continue to be some uncertainties. For example, if there was to be a new different variant of the virus to emerge that was resistant to vaccines, then that might mean that we'd have to have measures in place to combat the virus for significantly longer. There isn't any clear sign of such a variant at the moment, but because this virus can change and evolve, that's not something we could completely exclude at the moment.
Well, you mentioned there that by the autumn time there'll be not many, if any, restrictions still in place. What would be the few that would remain?
So it's very difficult to look that far into the future, and anything I say about this comes with a huge element of uncertainty around it. But, it's possible, for example, that we might still be encouraging people to keep their distance a little bit from others as much as possible at that stage. It's possible that we might be encouraging people to use face coverings in some settings. But beyond that, I hope it will be possible for most of society to be open again and functioning relatively normally. Although, as I said, there can be no guarantees this far away from the autumn.
We've had a few questions in, Professor Young, about what it actually means once you've been vaccinated. So how long does that immunity last for once you have received a COVID-19 vaccine? Is it going to be something that could be similar to, I suppose, the flu vaccine, where you'll have to be vaccinated every year?
So there are a couple of different factors to consider there. We know that when somebody receives the vaccine, that they show signs of being immune within about 10 to 12 days of their first dose of the vaccine. Not everybody who gets the vaccine is guaranteed to be immune. There's always going to be a small percentage of people who will still be at risk of getting the virus. Because the virus itself is new and because the vaccines are relatively new, we don't know for sure how long vaccine immunity will last. It could be 6 months or a year, or it could be that immunity with a vaccine lasts significantly longer than that. In the case of flu, the flu virus is one that changes all the time. It changes every year. And that's the main reason why we need a new flu vaccine each year, because the virus itself has changed. And we're not sure as yet in relation to the COVID virus whether it's going to change that much or that rapidly. We know it can change, but it may be that it changes more slowly than the flu virus. It's certainly possible that people may need a vaccine update every 6 months or once a year. We'll know that by the autumn, I think.
Well, still on the topic of the vaccine rollout, we were told today that almost 100,000 people have received their first dose of a COVID-19 vaccine. Are you able to give us any figures about the amount of people who have turned down the vaccine?
So what we know is that the considerable majority of people who have been offered the vaccine have agreed to take it. Inevitably, there have been some individuals who, when given the opportunity to receive the vaccine, have chosen not to for one reason or another. And there are also a small number of individuals who, by virtue of an underlying health condition such as an allergy, aren't able to receive the current vaccines. I don't have accurate numbers about the percentage of people who have declined, but we know that it's a fairly small percentage in terms of the numbers who have chosen to take it up.
Well, how much of an impact could that have then on the potential easing of restrictions later in the year?
Our hope is that as many people as possible who are offered the vaccine will choose to receive it. We need, I think, around 70% at least of the population to receive the vaccine and be successfully immune to the virus in order to prevent community transmission being an ongoing problem. But I mean, this is a virus which is now established, and it's going to be with us, I'm sure, for the rest of my lifetime and considerably longer. It's going to be a background virus that there will always be some cases of, and whether there be a need to have an ongoing vaccination programme to protect against its impact.
Well, moving on from the vaccines and the vaccine rollout, Stephen has got in touch with us asking about the new variant of COVID-19 that we've heard a lot about in the past few weeks. How do we know that this new variant is spreading? Is that something that's picked up when people are tested for COVID-19?
So the virus has been changing ever since it was first identified, which is what many viruses do. And at this stage, there have been many thousand different variants of the virus identified and in circulation at different times. Recently, there's been a lot of focus on what's referred to in shorthand as the UK variant, a variant of the virus that was first identified in the UK back in September, and which seems to transmit more easily by about 40 to 70% than the initial form of the virus. So that UK variant we know to be circulating in Northern Ireland. Some of the tests which are used to diagnose the virus, not all of them, they're called PCR tests, pick up the likely presence of the variant form. And then when we think it might be present in a sample, it needs to be confirmed by a process that sequences all of the genetic material of the virus to confirm exactly what its structure is. So that's how we can be certain that the variant form is circulating here.
So we know it's here. How prevalent actually is it here, Professor Young?
We're not certain at the moment, and what I've said when asked is that it's somewhere between 10% and 50% of cases, I think. It has the potential to increase and become more common very, very rapidly, which is something that's been seen in parts of England and I think in the Republic of Ireland as well. It's almost inevitable that we're going to see more and more of it. And we're currently working with colleagues at Queen's University and in England to sequence a much larger number of cases here so that we'll have a reliable estimate of exactly how common the variant form is.
Well, you mentioned there the different types of the virus that have been in circulation. Are the symptoms of COVID-19 changing? There's been reports of people testing positive without having, the classic symptoms of a headache or a high temperature or loss of taste and smell, and having more cold-like symptoms. Is that something that is happening?
I don't think the symptoms of the virus are changing, but we're definitely learning more about the symptoms and which are the most common. And our symptomatic definition of the virus has changed during the course of this epidemic as we've understood more about how people are affected. It's important to remember, I think, that probably around 30%, maybe more, of people who are infected with the virus don't have any symptoms that they recognise, although often on close questioning there is something mild. So people can certainly have the virus without the classical symptoms of continuous cough, high temperature, loss of taste and smell, and may have a wide range of other symptoms because this virus can affect almost any part of the body.
So if someone is presenting, I suppose, not the typical symptoms, would your advice still be to get a test?
At the moment, the answer would be no to that. We'd only advise people to get a test if they present with one of the three classical symptoms, or if they're advised to do so, to get a test as part of an ongoing pilot or research program. We do some testing of asymptomatic individuals. So, for example, if we know there's a COVID outbreak in a particular factory, then we may go to that factory and offer testing to everybody who works there in an effort to pick up the asymptomatic cases and to block the further transmission of the virus. But that's not something that we do routinely at the moment. The two universities offer some testing to students as part of a similar type of programme during term time when students are attending.
Coming back to the lockdown restrictions again, Professor Young, it's something that's affected all of our lives, but some might say that young people have been affected particularly badly by the various restrictions, whether that be missing out on certain opportunities, either career-wise or education-wise, or even, I suppose, just socialising in general. We've had a few questions in about this, but how much of a priority is dealing with the impact of lockdown on younger people for the executive?
The executive is absolutely aware of the impact of all of the restrictions on every part of society, but particularly young people. And that's something which a lot of thought and consideration has been given to. Maintaining schools open as much as possible has been a considerable priority for the executive. And schools being closed at the moment, I think, is a response to an exceptional situation and was a decision which the executive took reluctantly. So we're absolutely very aware of the impacts and how it's affecting all aspects of the lives of young people.
Well, you mentioned the R rates earlier today, Professor Young. You said it had fallen significantly. Firstly, before we get into this, could you just explain the R rate to us, I suppose, and why that is so important?
So the R number or R rate is a shorthand for the number of people who are affected on average by one person who has the virus. So if we imagine one person with COVID, how many other people do they infect while they have the virus? And if the average, if the answer is more than 1, so the R number is above 1, then the epidemic will spread. If we can keep the R number at less than 1, so that one person with COVID on average infects less than one other person, then the epidemic will shrink. And that's why the R number is so important, and that's why we are so concerned about trying to keep R less than 1 if we can. So less than 1 is good, above 1 is bad.
Well, due to the relaxed restrictions over Christmas, the R number had risen to about 1.8. Are you able to give us an exact figure of where it's at currently?
So we look at the R number regularly, and we publish the number Thursday of each week. What I will say is that it has fallen significantly since it was 1.8 last week, and that's an encouraging and positive sign. It means that what we've been doing since the 26th of December is working. And the key thing this week will be to see whether R has fallen to less than 1, which is where we need it to be, and ideally as close as possible to 0.7. During April, we got it down to between 0.6 and 0.7, which was great. And if we could get it close to that again, then that would, I think, give us the best chance of getting through this current very difficult period quickly.
But at the minute, the R number, is it sitting at the minute above 1 still then?
Well, as I say, we'll be making an announcement about that later in the week, and it forms part of the advice which we give to executive on Thursday of each week. But the number of cases is falling at the moment, so I guess people can make their own assumptions from that. And certainly the R number has fallen significantly from 1.8 or so last week.
Well, like you said there, an R number of higher than 1 means the virus is still actively circulating. With that in mind, how realistic do you think it is that the schools will be able to reopen again in February?
So just to be clear, I think when R is above 1, it's more than the virus is circulating. It means that the number of cases is actively increasing and that the epidemic is growing. Even with R less than 1, the virus is going to be circulating for at least several more months, affecting quite large numbers of people. So, the virus will certainly be circulating. If we can keep R at well less than 1, as I say, as close to 0.7 as possible, then there's certainly a bit of space there where the executive can consider what relaxations they would like to make at the beginning of February. And getting schools open has always been one of their top, if not the top priority.
Well, just on schools, Professor Young, what do we know about the transmission of the virus in schools? Because some have suggested that it's travelling to and from school and socialising afterwards is more to blame than students actually being in the school buildings. Would you say that's correct?
So we know that whenever schools are open, that the R number increases by somewhere between 0.2 and 0.4. So schools being open has an impact on the R number, which is a harmful one. Now that's going to be due to a number of different things. There will be some transmission of the virus in schools, although whenever schools are working very carefully, taking precautions, I think the transmission in schools is relatively small. There's no doubt, though, that people interact very differently when schools are open. And I guess, the listeners will absolutely be aware of that. People will walk to school with their friends, they'll walk home with their friends. They may meet up for a while afterwards for a chat. And in general, there will be more interactions, both within school but also outside school. As well as that, parents act differently when their children are at school. As a parent, if you're at home with your children, you'll tend to stay with them to look after them. But when your children are at school, as a parent, you may go out and meet with friends or interact more with other people. So there are a range of different factors, I think, which contribute to what happens to virus transmission when schools are open.
Okay, Josh has got in touch with us and he's asked, how will Northern Ireland better handle future outbreaks of infectious diseases following the COVID-19 pandemic? So I suppose he's asking, is there anything you think could have been done differently?
That's a really good question, and I think that it will be very important once this epidemic is past that we look back really carefully to see everything that has been learnt and that we could have done better. There will, I'm sure, be other epidemics, other pandemics, because of the way the world operates, because people move around so much and there's so much connectivity across the world. It's highly likely that other viruses will emerge in the future. So I'm sure that there will be lessons to be learned. I'm sure that there are things that we could have done differently, and that there'll need to be a very quick but thorough look back once we get over the next few months to try to establish what those lessons are.
What do you think some of those things are that could have been done differently, Professor Young?
So I think this is me expressing a personal view, but one of the important questions, I think, is the extent to which at the outset of an epidemic, you want to try to stop movement of people, which is generally how the virus will be spread. And that will be a question, I think, which lots of countries are looking at. It's not effective really trying to stop movement of people whenever you've already got a lot of the virus circulating or present in a country. It doesn't make a lot of difference. But before a virus is introduced, then that's something which it might be possible to think about. The other big area for me, I think, which has been important is testing. And whenever a new organism emerges and begins to spread, there aren't tests for it. I think next time, if this happens again, we'll aim globally to develop tests and roll them out much more quickly than we were able to achieve this time. I think there'll be a lot more resource and effort focused on the testing early on once a virus develops and is recognised.
You explained your role to us earlier in the programme, Professor Young. Your job is to advise the politicians on what measures you think are necessary to control the virus, but it's up to them ultimately what's actually put in place. That aside for a second, if you were able to introduce any measures straight away, would there be any restrictions you would bring in to control the spread of the virus?
At the moment, there wouldn't be any additional restrictions which I would bring in. What I do wish is that everybody would stick to the stay-at-home message. I think people should only be leaving their houses under exceptional circumstances at the moment if they really need to do something absolutely essential. There's so many other ways of communicating with people now. So many different electronic fora, social groups, etc. I think people need to focus on interacting in other ways and not have any face-to-face meetings indoors or outdoors as much as possible at the moment.
Well, we've talked about vaccines quite a bit tonight. I also wanted to quickly mention this. There were new drugs approved recently to help treat those hospitalised with COVID-19 in Northern Ireland. What can you tell us about them, and what does that mean for people who may have contracted the virus?
So there has been a lot of ongoing research to develop better treatments for COVID since the beginning of the epidemic. And what was announced just in the last week to 10 days were the results of some important research trials, which occurred partly in Northern Ireland and in which our patients participated, and some of our clinicians were involved in running those trials. The patients who get most severely ill with the virus, some of them, the illness is caused by an overreaction of the immune system. So the body responds too strongly to the virus and generates a lot of inflammation, which is then harmful to the body. The drugs this week were drugs that are called interleukin-6 receptor antagonists. So they help to block that excess inflammation. And we'll be able to roll out those treatments, I think, very quickly to the patients who are most severely ill with the virus, what they show is that they've reduced the risk of dying by about 25% on top of existing effective treatments. And they also reduce the average length of stay in hospital by about 10 days. And that's really a very substantial benefit for the most severely ill patients, which will help us get through this wave and through any subsequent increases in infection.
Well, that's a positive note, I think, to finish on. We're out of time and we'll have to leave it at that for this week. But thank you, Professor Young, for answering those questions and coming on tonight to explain those things to us. Thanks as well to everyone who got in touch. We didn't have enough time to get back to all of you, but hopefully we've helped answer your questions. Don't forget that you can keep up to date with the latest developments on the BBC News NI website, which you'll find at bbc.co.uk/newsni. You can follow us on social media as well. We're on Facebook, Instagram and Twitter. Just type in BBC News NI and you should find us on there. That's it from us. Until next week, stay safe.